Thank you very much. I'm impressed to see a full house. It's a busy time, obviously, but thank you all for making time, both online and in person. I've known Dean Goodman for a while, so I'm delighted to be here and back at NYU, back in the village, because it means a lot to me to be part of this community. And thank you for making time. So I have lots to talk about. So I'm going to jump right in. And the topic officially is AI in healthcare, from hype to harm reduction. I can talk for hours, but I promise I will only speak for about 45 minutes, and then we'll leave time for Q&A, because hopefully, there'll be 15 minutes at least for that. But if I go over time, Zach will raise his hand and I will slow down or stop early. So some disclosures. I like to be transparent. I used AI for 5 of my slides, so you can guess which ones, but I wanted you to be aware of where I didn't want to pretend that I came up with all of this by myself. So what I'd like to do is talk a little bit about public health and why I went into public health. As you heard Dean Goodman say, I was health commissioner on Long Island, and I'll talk a little bit about that, not too much. I'll talk about the physician shortage that we have in this country. We actually have a healthcare workforce shortage, not just in medicine, but in nursing and pharmacy and many other healthcare fields. So I'll talk a little bit about why that's important in my day job. And then I'll jump into what's happening in artificial intelligence. I'm sure, and we'll try to make it interactive, but I promise I will not call on you. How many of you have ever attended an AI talk? Of course, all of you have, just about. But in all of those talks, do you learn something new at each one that you attend? Yes, me too. I've attended at least 24 talks, and I still learn something new because it's such a dynamic area. There's so much happening. There's something new happening literally every single day. Just this morning, I learned some new things. So we'll talk about that. So a little bit about me. I was raised in Brooklyn, New York. Do we have folks from Brooklyn here? All right. We got Brooklyn in the house, so that's good. Really what was pivotal for me was getting my public health degree, because I never thought I would do that. I wanted to be a doctor to take care of patients at the bedside, but I had gotten a job as a residency director at Long Beach Medical Center, which is now closed because of Hurricane Sandy. It got damaged. But I didn't really understand how to run an organization. So Harvard at the time had a healthcare management master's degree at the School of Public Health. So I learned about how to manage budgets and large organizations, but I also learned about epidemiology and statistics and really what public health is all about. And then when I saw there was an opportunity to become health commissioner in Suffolk County, there was literally an ad in the New York Times. And I remember looking at the ad and saying, that description sounds like what I have. Could I ever be a health commissioner? Let me try. One thing led to another. But that was really rewarding for me to be health commissioner for about 2.5 years. This is what Suffolk County looks like. And I remember thinking to myself, wow, I am now responsible for the healthcare of 1.5 million people in that area. That's huge. That's 900 square miles. Suddenly, I'm in charge of a budget of $436 million, $500 million almost, and 1,300 employees. I took it very seriously. I remember being told, Hank, you can still see patients if you like on the side. Like, how? There's no time that I could possibly build in. So I devoted my full time to the job. And sure enough, it didn't happen right away. But 2 years later, we had the H1N1 pandemic. Remember that? Before we had COVID, we had H1N1, commonly known as swine flu. And we thought this was the big one. Since 1918, we had been preparing for it. Every local and state health department in the country, if not the world, always prepares for the big pandemic. And so I remember this is me at a news conference announcing the closure of all of the schools in the Deer Park School District because H1N1 was becoming a problem. We were early. New York, I was on the phone all the time with Tom Frieden, who was the New York City Health Commissioner, who later became CDC director. And we thought New York was going to be where this begins and then spread throughout the world. But thankfully, it wasn't that bad. But I remember sleepless nights worrying about what's going to happen. I will tell you, probably the scariest time as a health commissioner was somebody just came to my office and said, Commissioner, we need you to sign off on this requisition, because they have me sign things all the time. And luckily I had a lot of smart people who I worked with, who knew what they were doing. And I said, what is this? They said, we're ordering some body bags just in anticipation. I said, how many? 10,000 for Long Island. I said, where did you get that number from? They said, statistical analysis, looking at epidemiology, looking at the 1918 influenza pandemic. How much, I mean, they said, trust us, we did the math. I'm like, oh my God, 10,000. Of course, we weren't allowed to share that number with anyone, but this was, scary. And thankfully it didn't turn out to be that bad, but I don't know what happened to the body bags, but hopefully we return them. But I mean, can you imagine? We even had discussions about calling in the clergy, because if you're going to have 10,000 burials, first of all, where do you bury them? We had to start thinking about burial plots. We had to think about allowing families to visit. Then I was told you can't have families visit because it could be a problem with spreading of the virus. And then I remember saying, someone suggested, why don't we call in the clergy ahead of time to prepare them about the eventuality? I said, not a good idea. They're not going to be able to keep this a secret that we just did this. So let's just play it by ear. Just to give you an idea of what it's like in public health. There are positive moments of where you can make a difference, but there are also scary moments like this. So shifting gears to what I do now, you already heard Dr. Goodman mention, the Federation of State Medical Boards has been around since 1912. Licensure is at the state level, both for doctors, nurses, and other health professionals. That's always been the case since the nation was founded. When the nation was founded, decisions were made about who's going to be in charge of the federal government. The federal government decided to be in charge of the military and foreign policy. That makes sense. The states were already doing licensure of physicians and nurses. So they said, why don't you keep that with us? And under the 10th Amendment, the states license doctors and nurses. So that's why we don't have national licensure. We have state-based licensure. So at the FSMB, we're a very democratic organization. We have a House of Delegates. Every state board has representation during our House of Delegates. We vote, we discuss things. Now, when we vote, and if we agree on a policy, for example, 2 years ago, we voted on an AI policy. It doesn't become law because we're not Congress, but it's a guidance. It's up to the state boards what they want to do, but we are very careful with our guidance because state boards can adopt it verbatim, and sometimes they do that, or they'll cut and paste what we say, or they'll completely ignore what we say. It's entirely up to them. I'm not bothered if they ignore our policies. That's entirely up to their own jurisdictions. But this is sort of how the process works. Shifting gears, let's talk about the number of physicians we have in the United States. You may have seen these numbers again before. This is from the Federation of State Medical Boards. We have records of every single doctor and PA, and where they are licensed, where they went to medical school, where they did their training. So I can tell you, as of December 31st, 2024, there are exactly 1.08 million physicians, MDs and DOs in the United States. Is that enough doctors? I mean, you already heard me mention that I'm going to talk about physician shortage. How do you know how many physicians you should have in a country or in a jurisdiction? Is there any number that we should know? Is there a guide generally? Does anyone know? Okay. It used to be years ago, the World Health Organization used to say that you need at least to have 1.7 doctors per 1,000. So this, by the way, adds up to about 3.18 per 100,000. Sorry, 3.18 per 1,000, which is 318 per 100,000. But the World Health Organization wisely moved against those kinds of hard numbers because it's not the absolute number of physicians, it's where they are practicing. And so there's a significant maldistribution. We may have possibly enough physicians in Manhattan, but that doesn't mean upstate New York has an adequate supply of physicians or subspecialists. So the numbers themselves only tell part of the story. Just like the country is diverse, we're a melting pot, physicians are also, just like nurses, they come from all backgrounds. The 1.08 million physicians come from 2,392 medical schools all around the world, from 171 countries. The largest countries that provide physicians to the US come from India and Pakistan. Those are the number one and number two countries. Now, women are increasingly making inroads and playing a greater role in healthcare, both in the US and around the world. In the US, we're now at 39% of all practicing physicians are women. That's even a change from when I joined the FSMB, because back then it was about 20%. So even in about 15, 16 years, the numbers have doubled. What about medical schools? Does anyone know what percentage of medical school students are women? It's about, it's actually, it crossed the 50% threshold. It's like 52% now. Now, how does this compare, since this is GPH, the School of Global Public Health? How does this compare with the rest of the world? Does anyone know what percentage of physicians in, let's say, India are women? Take a guess.
30.
30? It's actually 14% so that's still a small number, but if you looked at their medical school students, that's really what can tell you what the future is like. 64% of their students are actually women. So that demographic is going to change. Just like it's changing in the US, it's going to change in places like India. Interestingly enough, Pakistan, their number of physicians who are women is 50% already. And this may surprise you, the number of women who are medical students in Pakistan are 75%. That's a lot. The challenge there is not all of them, once they graduate, practice medicine. They get married, they decide not to. So it's a great degree to have, but unemployment among female physicians in Pakistan is a big issue. Something like 34% of them just decide not to be employed. So that's a challenge for a country like that. Of course, maldistribution is the big issue, and this is a slide that you may be familiar with. It's from HRSA, the Health Resources and Services Administration. If you looked at the dark green and dark blue on this map, those are the metropolitan and non-metropolitan areas that have the most number of health physician shortage areas, health professional shortage areas. And it's all over the map. It's all over the country. There are areas of shortage, even in cities, as well as in suburban and rural areas. So we may have an absolute number that's adequate, but clearly there are disparities all across the country. And so this has been a challenge. How do we deliver care if we don't have enough providers or healthcare practitioners who can do that? So one of the things the FSMB did was, back in 2013, we got all of the state medical boards in a room and we said, look, we need to do something about this. We don't have national licensure, but right now our processes by which we license doctors is a little slow. It can take weeks to months to get someone licensed to practice medicine. And if you have one license, you want to practice in another jurisdiction, it may take several months to get an additional license. Can we do something about this? So that led to this interstate medical licensure compact idea. How many of you are familiar with the Interstate Medical Licensure Compact? Couple folks. I know Dr. Horowitz is. So what we decided was to create like a TSA pre-check, that if you as a physician meet all of these 9 criteria, we settled on 9, participating states agreed to issue licenses to practice medicine instantly. I repeat, if you as a physician have these 9 eligibility requirements and you meet them, participating states are willing to issue you a license literally instantly. It's not electronic, so they still have to mail it in most cases, but it's pretty much participating states have agreed to this. Now, how many physicians would meet these requirements? Our data show that 80% of the nation's physicians, if they wanted to go through this process, can do that. How many states have done this? 43 states, plus DC and Guam, have signed laws that they support this. So in these 43 states, if you have these 9 criteria as a physician, you can get as many licenses as you want. That's great for telemedicine, if you want to practice telemedicine in multiple jurisdictions, or if you live in a border state, let's say you're in New York and your patients are sometimes in Jersey, sometimes in Connecticut, you can get licenses in those states too. However, New York is not yet one of the signatories, neither is California, neither is Oregon, Virginia, South Carolina, Massachusetts is thinking about it. New York is thinking about it. They haven't signed it yet, but maybe they will, maybe they won't. From our perspective at the FSMB, it's entirely up to the states. There are complicated reasons why they're not ready to do that, but this has really helped. 180,000 licenses have been issued through this pathway to allow physicians to practice medicine in multiple jurisdictions, either in person or by telemedicine. So that's one way that you can help. Another way, more recent, is licensing physicians from other countries that have already completed their training. For decades, if you are a physician who trained in cardiology overseas and you came to the United States, you would have to do cardiology over again. Why? Well, because we don't know what you might have been taught overseas, and you need to understand the US system. So basically, you have to do your training again, and many people have. But because there's such a shortage, people have wondered, why do we make them do that again? Is there not some other way that we can acknowledge and recognize their training? There must be another way, because it seems like a waste of years. Maybe we can get more doctors. And so this licensing of internationally trained physicians is moving forward. There are about 20 states that have signed this into law in the last 3 years. They haven't worked out all the details. There's literally 10 people who are in this sort of process, but it is something that is catching on. Again, a way to address the healthcare access issues in our country. So with that, I'm going to now go into talking about AI, which is the subject of this talk, but I wanted to get that in there just so you understand the broader perspective. So AI, how many of you by a show of hands use AI? Just raise your hands. Okay. Just about everyone. Some of you might be shy, don't want to admit that you do. That's fine. This is Arthur C. Clarke, a great science fiction writer. One of the co-writers of 2001: A Space Odyssey. You may remember. He said, any sufficiently advanced technology is indistinguishable from magic. And honestly, it seems that way. Every day there's something new. It's amazing what they can come up with now, and you can actually use it in a way that you never thought possible. So it does sound like magic at times. So does anyone know where this might be? Does anyone know what this is a picture of?
Data center.
It's a data center. Yes, correct. It's a data center in Carlisle, New Carlisle, Indiana. Anybody here from Indiana? Okay. This is 1,200 acres of land that have been bought out by Amazon. How many people use Amazon? Why does Amazon want to create a data center? Because they want to help deliver products to you. They want to understand what you're thinking so they can anticipate your needs, presumably. But they're also partnering with Anthropic and working on Claude and other AI technologies. This is going to cost $11 billion. This will be completed by 2035. There's going to be 30 buildings involved. This is one data center. And there are data centers like this all over the world that are being planned. The electricity consumption is significant. It's 2.2 gigawatts, which is the equivalent of half the energy needs of the state of Indiana for 6 months for this one data center. Yes, there are lots of implications in public health, water pollution, noise pollution. There's going to be sounds. Some say as much as 65 decibels of sound is going to be generated just from the machines that are working to keep this data center going. As well as water pollution and all air pollution and all kinds of other pollution. So interesting. And we can get into discussions about, sort of the specifics, but this is what's happening around the country and around the world because you need energy to make these data centers work. So let's talk about the evolution of artificial intelligence. And these are 4 important dates that I think are helpful to remember. The term AI, artificial intelligence, began in 1955 when a very smart man at Dartmouth, John McCarthy, who was actually an assistant professor of mathematics, said, we should get together and have a meeting to talk about using technology to think in ways that we've never thought possible. Up to that point, AI was principally talked about in science fiction. But Dr. McCarthy wondered if we can start talking about using machines to think in ways that we haven't even thought of. And so he planned for the summer of 1956 to invite the world's experts in sort of this sort of thing. And about a dozen people came together in the summer of 1956 to talk about AI. That was the term that they used. Some years later, 1968 is when 2001: A Space Odyssey came out. And that's when agentic AI became visible for the general public. How many of you have seen 2001: A Space Odyssey? Okay, if you haven't seen it, I wish we could make this, Dean Goodman, a required viewing. Maybe you can get the rights for it and show it at NYU because I think it's worth seeing because it's a great movie. It's a long movie. I just saw it recently. I was telling Zach, and it still holds well, even though it's a movie from many years ago. Cinematography is amazing. The writing is amazing. Essentially, the concept, I'm not going to give away the whole story or the plot line, but essentially the concept is a bunch of astronauts are traveling to Jupiter. We're talking about going around the moon. This is now 1968, talking about a mission to Jupiter. And the AI that's being used to help those astronauts get there has been given 2 instructions by its designers. And remember, all AI machines involve humans who create the hardware and the software. In this particular case, there's 2 messages that AI is told. The first message is, you must always be truthful. That's nice. That's always good for machines to be truthful. But the second message is, do not tell the astronauts what this mission is until they arrive, because it's super secret. So already there's a conflict now. AI is told, always be truthful, but don't tell the astronauts what's happening. So that's where the conflict begins, because at some point, the astronauts start wondering what this mission is all about. And they keep asking Hal, who's the AI computer, and Hal can't really tell them, because while it's supposed to tell the truth, it's also supposed to keep it a secret. And Hal decides it has to choose, and it makes a decision. Worth seeing. I'll leave it at that. 2022, of course, is when AI became publicly available as a publicly available chat, essentially for free. When OpenAI created ChatGPT, everyone has heard the story. This happened in November of 2022. And in the last 3 years or 4 years, it's just amazing how much has happened. This year is the year of agentic AI, where AI not just is a great sort of resource to study and look up things, but also can do things. That's what agentic means. It has agency. If you're thinking of traveling somewhere, just tell it where you would like to go, and it will give an entire itinerary. It'll make plane arrangements. It'll make the car arrangements. It'll find a tour guide. If you give it some parameters, it can actually go ahead and order those things for you. If you tell it, well, I don't want to spend more than this amount of dollars, give me an entire itinerary. I mean, that's an agentic AI type of system. Now, the other thing that's fascinating is how quickly AI has really moved forward. The internet, remember the internet? That took 13 years to move forward. And I looked it up. 1991 is when the World Wide Web became available, but it wasn't until 1993 that it became publicly available. So some of you are old enough to remember when that happened. But it took 13 years for 800 million people to get on the board and start using the internet. ChatGPT, within 2 years, basically had almost 1 billion people using ChatGPT. So people are using it. There's an excitement out there. But let's talk about how they're using it. This sounds like a busy slide, but this is an important slide. This is put together by Travis Johnson, who's an AI entrepreneur from California. Each of the gray squares represents 3.2 million people. So this is basically the entire world's population. The gray 3.2 million people are people who've never used AI. So as you can see, the majority of people have not used AI. They're willing to try it, but they haven't used it yet. The green are people who have decided to use AI that's free. Now, what does that mean? So if you think about it, when was the last time you did a Google search? Raise your hand. Okay. And what does Google searches usually take you to when you ask a question? If you ask about, I don't know, anything, where does it normally take you to?
Gemini.
Well, it takes you to the links normally, right? Like if you ask about where's the nearest CVS, it's going to give you all of the websites for the nearest CVSs, right? But lately, depending upon what you ask, it uses Gemini, which is AI, to give you an answer. And you might think, that's kind of neat. It gives me more than just a link. It gives me information. But this is free AI. So be careful. And so my advice is never to use free AI, because what you may not realize is you are actually, by asking your question, you are giving permission to AI to know that you are asking that question, and they can use that information to develop a profile of you and use it as they see which, including for training purposes. So after a while, if you use Gemini a lot, they will figure out who you are. And if you want to give that information away, that's fine. But a lot of people don't understand that. And so a lot of people in the green are using free AI and are saying, yes, I use AI and it's pretty cool. But they're also opening themselves up in ways that they hadn't thought about. So the privacy issue is a big one. So the yellow are the people who actually pay for AI, $20 a month on average. That's what I would recommend. If you're going to use AI, pick a platform, get a paid subscription because there are more firewalls. And those firewalls and guardrails prevent information and the questions that you ask to be used in ways that you didn't plan. At my organization at FSMB, we have an enterprise-wide contract with Claude and Perplexity. So that's the only system we allow for our employees. It's controlled and it's within a sort of a closed system. And it's not like an OpenAI where people can use that information to learn more about you. So it's a little bit more of a protected system. And then the red dot, one red square, is 3.2 million people who are actually using AI for coding. These are the really, really IT people who are doing all the fascinating, exciting things all around the world. Those numbers will increase as well. My advice to you is, sounds like most of you are not in the gray. That's fine. Try not to be in the green, be in the yellow. I'm not recommending any particular platform. Use whatever platform you like, but just be aware of free versus costly AI. At the FSMB, way before 2022 and ChatGPT, we started worrying about AI because we oversee the licensure of physicians, and we invited our colleagues from nursing and pharmacy and other professions. We wanted to talk about this because it was starting to be talked about in healthcare, and we wanted to sort of understand AI. So it was kind of a new language for us. We had experts, we had someone from MIT, director of the computer science and artificial intelligence lab at MIT came. We had lawyers, we have industry people from Google, just sort of trying to understand what's happening in this space way before ChatGPT happened. Now, since ChatGPT happened, in the past year, we have created an Office of AI Innovation because we want to be on top of what's happening. We want to harness its good attributes and understand better its uses, not only in healthcare, but also in medical regulation. And then my chief operating officer said something interesting just a few months ago, which blew me away. His name is Mike Dugan. I said, Mike, how much AI are we currently using at FSMB? And he thought for a second and he said, Hank, I think everything we do with technology now involves AI. I said, everything? Oh my God, that's big. But that's how powerful and useful it can be. By the way, that reminds me, 2 years ago in January, I was in Silicon Valley attending a meeting, and the chief medical officer of OpenAI, the founder of ChatGPT, was there. And he was asked two very interesting questions. One question was, is it true that anything and everything ever produced on the internet has been absorbed by AI? And he thought for a second, and he said, yeah. Wow. Anything ever produced on the internet has been absorbed by AI. But he said, but I caution you, it doesn't mean forever. For instance, if you were to take your iPhone this afternoon and take a video, or even take a video of me talking, AI is not going to be aware of it because you didn't upload it yet. But if you're talking about material that's been uploaded to the World Wide Web, yeah, most AI platforms have absorbed everything in there. So when you're asking a question, it is looking at the entire World Wide Web of anything ever produced and scanned and giving you an answer based on that. That's powerful. The other question he was asked was, are you ever going to get rid of hallucinations? How many people know what an AI hallucination is? And most of you do. It's basically when AI tries so hard to give you the right answer that it actually lies. And it's almost, I don't want to give away too much from 2001: A Space Odyssey, but there's some echoes of that in that movie as well, because AI wants to be helpful, and sometimes it creates references that don't exist, that sound real, because it really wants to help you. And so hallucinations can be a problem. And so the chief medical officer at OpenAI was asked, are we ever going to get rid of hallucinations? And again, he thought for a second and he said, no, because errors will always occur, and you need humans to make sure that if they're using the machines, they understand that. Because it's like saying, can you ever get rid of medical errors? The answer is no. You're going to do everything possible to minimize it, but you cannot make them go away. So what are some of the current uses of AI in healthcare? You've heard about this already. Clinical decision support. And I'll give you a good example. My mother-in-law was recently hospitalized in Canada, and she had and I'm an internist, so I generally am good with primary care, but she had so many interesting things going on that we really couldn't figure out what was happening. And so with the permission of my wife's family, I used AI, a closed AI, so I wasn't using an open AI, and I just punched in lab values and some x-ray findings, and the things they came up with as possible causes matched what the doctors were saying. And in fact, in one or two cases, it suggested things that the doctors hadn't thought about yet. And I thought, wow, this is really good because I'm using clinical decision support to make us be better at taking care of a human being. That part sounds good. Also documentation, workflow, charting, ambient listening, so that when you go to the doctor's office, they don't put a laptop in front of you and they actually can just have a normal encounter and maybe give permission to AI to listen in. How many of you have been to the doctor where they had AI ambient listening? Some of you have. What did that feel like? Was that cool or was that? It wasn't cool. Why?
I declined.
You declined?
Yeah.
Okay. Because?
I declined I have a lot of issues with the ethics of AI and the
Yeah.
use of it, and I don't feel comfortable with that.
Yeah.
Especially as like a niche medical case. Typically when I visit doctors, like there's a lot that could go wrong with that.
Absolutely. And so some people are going to say, yeah, sounds great. Anything to get rid of that machine between me and the doctor. But others are a little worried about, wait a second, I'm here to have a private conversation with you, my doctor. And I don't want a third party listening in, even if it's going to make your life easy with charting. I don't want to do that. But it is something that the doctor or the practitioner, nurse practitioner or others, are supposed to tell the patient to get their permission. Now, why is this important? Well, there was a lawsuit recently in California where a patient said, I did not give permission for AI to be used. And she learned afterward that they transcribed her, summarized her visit. And she said, I never gave permission for that. Now, the doctor claims that she did. And she said, no, that yes, and the approval, I never signed that. That sounds like an automated thing. And so this is now a lawsuit. So you have to be careful. We're going to see more of this because people are not always going to give permission, and healthcare is going to be tricky because some patients, you're going to reach a point where healthcare will involve so much AI that if a patient comes in and says, doctor, I'm happy to see you, but please don't use any AI, the doctor might think for a moment and say, I don't know if I can do that because AI is all over the place. I don't know if I can just see you without AI. We're not there yet, but we're sort of heading into that. So interesting things are happening in healthcare. How many of you have a medical background? Anyone? Okay. So this is a complicated slide. It's for a disease entity called heart failure with preserved ejection fraction. It's one of the things we see in cardiology or internal medicine. And diagnosis is not easy. And yet the prevalence of this is about 3 to 5% of the general population. Half of the patients with heart failure have heart failure with preserved ejection fraction. This is the algorithm we typically use to figure out if you have it. Well, there was an interesting article published last January, about determining if you have this by letting AI read your EKG. And you might say, well, what, most doctors should be able to read an EKG, right? But it turns out there are things in your naked eye that you can't see that AI can pick up. So these are some examples of EKG findings that a machine can pick up much, much faster and better than a human being, even a professional, experienced cardiologist looking at an EKG that actually might give you the answer and the diagnosis a lot sooner. So that's an example of AI really being helpful to the doctor. And I think we're going to see more of this. Another example is in gastroenterology. How many of you have either gone through or know somebody who's gone through small bowel capsule endoscopy? Okay, so then this involves swallowing a pill, fairly large pill, that has a little camera at the end that as it makes its way down, takes video and pictures to determine if you have pathology. It's a lot, easier, one might say, than putting a scope down your throat, even though you're anesthetized and whatnot. It's been around for 25 years, this technology. The problem is the images that this generates are anywhere from 5 to 10,000 images, which then have to be analyzed. That analysis can take at least a half an hour or more. AI can do it in 3 minutes. So again, here's another example of AI helping something we already do, And it involves something called convolutional neural networks, CNNs. But this is among the things that we're starting to see in radiology and in imaging. Another example is in oncology. I'm not going to spend too much time on this because I'm sensitive to the time, but there are ways in which part of the challenge of cancer is trying to understand what kind of cancer, what kind of treatment is necessary, what's the best treatment for this particular person's genome. And I think AI is going to make a big difference in that as well. What about infectious diseases? Definitely. We have a big problem with antibiotic resistance, figuring out which antibiotic is, which microbe is involved. And also in sepsis detection. We may be able to determine sepsis 4 to 8 hours before we would otherwise if we used AI. And time is important in infectious diseases. It's also important in public health. And so one of the things we're really hoping for at the FSMB is that medical errors, the wrong antibiotic, the wrong treatment will go down if we use AI. And I think there's great opportunity for that to be in place. What about in public health? These are some examples where AI could be very helpful in public health. Multilingual risk communication. If you have an outbreak and you need to get the word out, you can do it in 20 languages at the 4th grade reading level within 5 minutes. Write something out, have AI convert it to the 4th grade level in English, have it do it in 20 languages, boom, you're done, send it out. That's amazing. Also for health information assistance, 24/7, people are calling in, asking questions. AI can help respond. Rapid literature and policy syntheses, automated document reviews, surveillance support, synthetic data, and scenario generation. The possibilities are endless. So if you're familiar with AI, that's great. Become more familiar because it's really going to be a big part of public health. Since we're global public health here, so this is something that just came out last November in India, where they've come up with an AI tool to detect diabetic retinopathy in the general population without an ophthalmologist. So part of the biggest challenge is getting people to go to the ophthalmologist. There aren't that many ophthalmologists. And so this shows promise in using a tool to diagnose diabetic retinopathy and therefore diabetes a lot faster. So another example of how AI can be really helpful. How many of you know Kamran Khan? By show of hands? One person, maybe two. So Kamran Khan is an infectious disease specialist. He graduated from a school of public health a little bit north of us. I believe it's called Columbia. And Dr. Khan invented an AI device or technology or platform to do disease surveillance. And he did that in 2013. And this came in handy in 2019 when his AI platform detected an early signal in Wuhan. His platform picked up that for some reason in Wuhan, China, in late December of 2019, the people in that city were suddenly Googling and searching for pneumonia, fever, cough, respiratory infection. And on December 30th, his company picked this up and said, what's going on? The CDC hasn't said anything. The WHO hasn't said anything. Something is happening. And he decided to share this with the world. And suddenly the world is like, what's happening in Wuhan, China? This happened 6 days before the CDC announced that there may be an outbreak and 10 days before the World Health Organization did that. So I think there's real value in AI in predicting a future pandemic. So that's powerful. If we can, again, the sooner we know, the more we can do to intervene. Now, of course, NYU has an expert on this as well, Dr. Rumi Chennara. I don't know how many of you have worked with Dr. Chennara yet? Some of you have. So she's a world expert. She's done amazing work in looking at cholera in Haiti or looking at immunization rates in Pakistan. But she's also your resident expert in using technology and social media to determine disease surveillance before it happens. So what's the problem with AI? The problem is, well, the good thing is on the left side, cognitive offloading. There is so much cognitive overload. There's so much you have to know in medicine and in public health. Wouldn't it be nice if you could offload some of that work to AI? That's fine. The problem is cognitive surrender. That's what bothers state licensing boards and regulators a lot. Because at some point, you might decide to just trust AI completely, which would be problematic if there are hallucinations and mistakes. And what happens when you make mistakes in public health or medicine? People can be harmed, people can die. So that's a conundrum of sorts because the technology is so exciting, but don't forget that it can make mistakes as well. So how do we avoid harm to underserved and underrepresented communities? We want to make sure we have an intentional design at every stage, from data collection to deployment. And we're treating equity as something we think of early rather than as an afterthought. The NAACP has a wonderful paper came out last year. If you haven't seen it, you should. It's called Building a Healthier Future, How to Use AI Thoughtfully so that you don't inadvertently omit communities that could be harmed if you didn't use it in the right way. Really, the most foundational fixes at the bottom there: broaden the data deliberately to capture racial, ethnic, gender, linguistic, and socioeconomic diversity before putting together data and sort of working backwards. Moving forward, that's your responsibility to make sure all research projects, all clinical projects have that in mind. These are some of the regulatory considerations for FSMB and the medical boards. Poor implementation of AI. There's lots of products out there. No one knows which are the best yet. Professional and ethical duties, bad actors, AI hallucinations. The European Union has some really strict rules that they're really enforcing rather well. The United States, under the current administration, actually has a different approach. Their approach is they've rolled back some of the previous oversight under the Biden administration. They favor a rapid AI adoption with fewer restrictions. Why? They want America to succeed and be the best at AI. So that raises some concerns about, so what's happening if that's happening at the federal level? The states are stepping in by putting in some of those guardrails. So FSMB, and I'll make this maybe my last slide, put together a policy recommendation that was adopted by our House of Delegates 2 years ago. And so we basically told doctors, don't be afraid of AI. Go ahead and use it, but recognize that you, at the end of the day, are the licensed entity, not the machine. And so you have a responsibility, if you're going to use AI, to use it wisely, to use it thoughtfully, and that you understand the technology. If you agree with AI and its recommendations, by all means, use it, but document that you're doing that. Can you disagree with AI? Absolutely. And that's allowed too. We don't want people to have that cognitive surrender, but document when you disagree with AI as well. Documentation is going to be the key in case there's any harm. So I have a few other slides, but I'm going to stop there because I want to leave time for Q&A. But right now, I think the last thing I'll say is some interesting things are happening in AI. There are 2 states, Idaho and Iowa, that have just introduced legislation to create a licensing board for autonomous AI. In other words, machines they're proposing should be licensed to practice medicine without any human intervention. Now, they introduced it late in the legislature, so it's not going to pass, but they kind of introduced it to get people talking about it. So we're going to be talking about it at the FSMB's annual meeting in 2 weeks, but that is something, honestly, I didn't think was coming. So we can talk about it. We'll see where it goes. So be careful out there is my final message. But thank you for your attention. And again, keep studying, learn, ask questions, and good luck in your career in public health.